Black masculinities and structural determinants of HIV vulnerabilities are the themes of the third episode of the weSpeak podcast. The speakers will also talk about policies and practical strategies to reduce HIV-related health disparities among Black men and the communities. Hello, and thanks for joining us for the podcast's third episode. I'm Joy Usiago, your host for the series. Dr. Rogers Antabe, an assistant professor in the Department of Health at the University of Toronto Scarborough and one of the community research coordinators for weSpeak, is on this episode. Dr. Wesley Oakes, a co-investigator and senior lead, Strategic Partnerships and Health Equity Initiatives at the Ontario HIV Treatment Network, joins Dr. Antabe. Studies have shown that heterosexual African, Caribbean, and Black ACB men are emerging as a vulnerable group to HIV, yet to get the attention of policymakers in the health sector in Canada. Data from the Public Health Agency of Canada shows that ACB people are 12.5% more likely to get infected with HIV than the rest of the population. The group also represents over 25% of new HIV cases, yet ACB people constitute less than 5% of the population. Dr. Wesley Oakes gives a background to Black communities in HIV in the North American context.
In this part of the world, in North America, Blackness and HIV tend to be associated in a particular way. When we think about HIV globally, we often tend to think about HIV along these two repertoires. The first is, North American HIV or Western HIV. The Western epidemic has been an epidemic that has affected primarily gay white men. And the African epidemic is a heterosexual epidemic, but it's also a Black epidemic. And I think those tend to be the primary registers. And then when Blackness does feature in the North American context, it tends to feature as a pathology, as a way of explaining certain types of deviant behaviors within Black communities that perpetuate the onward transmission of HIV, right? So Blackness is normally understood as being that thing inside people that is responsible for these behaviors that are morally questionable, reckless, and terrible for community health.
Dr. Rogers Antabe asserts that the Black community's stereotyping also accounts for the vulnerability to HIV in the ACB communities.
When it comes to the Black community, I think the narrative for what accounts for HIV among us, or what accounts for HIV prevalence among the Black population, is actually what Wesley describes as pathological, right? So we are in a context where people actually assume, or people think that when you talk about Black people and you talk about HIV, you are talking about a certain deviant behavior. You are talking about a group of people that are not interested in the kind of, they are not interested in their health. They are just interested in living some form of lifestyles that brings all these HIV risks among them. The group within the Black population that also emerges as people that are further blamed are also the heterosexual Black men. As a matter of fact, they are actually seen as a culprit, or they are seen as people that are leading the spread of HIV in the context of North America. So even in the work that we did, most of them actually have this kind of disconnection with AIDS service organizations and some people that provide services, because they already think that they blame them for the spread of the disease. They blame them for most everything. So for that matter, they just want to just be in their corner. They don't want to go and further be looked at as culprits who are spreading the virus in North America.
Even in the media, the portrayal of Black heterosexual men hurts the group, as observed by Dr. Oakes.
Black men, for example, in Canada have been overrepresented in media portrayals around the non-disclosure of HIV. So the criminalization of HIV in Canada has focused a lot, at least in the media, on heterosexual Black men as being responsible for, transmitting HIV to their partners. And that feeds into certain stereotypes that we already have, right? Stereotypes that are not HIV related, but that are about Black men's sexual appetites, right? And one of them being that Black men can control themselves. They are sex fiends. They can turn down sex. They are people who seduce others, women specifically, and so on. So these narratives are really, really powerful, right? When it comes to describing HIV in Canada.
Dr. Antabi gives a case study to support Dr. Oakes' observation.
One of the stories I would like you to follow is the story of Charles Sionga, somewhere within the late 1990s, early 2000s. And he was a migrant, Ugandan migrant to London, Ontario. You just follow the media portrayals of who Charles Sionga is, and that gives you just a picture of how people think Blackness is associated with the spread of HIV. Like, as a Black man, you're almost always a guilty, or you're almost a culprit when it comes to the spread of HIV. So in our own work, one of the things that I found is that these kind of stereotypes about Black people and how they and how they practice, let's say, their masculinity or how they live their lives, tend to create a lot of problems for Black people themselves. So, for instance, especially among very young Black men who actually lived in a context where there is a sense of not belonging, they don't have a sense of belonging to the Canadian space. So the Canadian space is created not to actually cater for them to have a certain form of identity. They tend to embrace some of these stereotypical depictions of what Blackness or what Black men are supposed to do. And by endorsing those stereotypes about what Black men are supposed to do, the number of sexual partners they're supposed to have, they're not turning down sex, so many of those negative stereotypes, they tend to embrace and internalize them as something that is true of Black identity. And that increases their risk of HIV, even though a majority of them have realized that this is not the case.
The guests talked about structural barriers and the impact on the lives of Black men from the stories shared about HIV and vulnerabilities in the focus group meetings.
It could be as simple as this, Joy. You know, you can't get a primary care doctor. You're looking for a GP and you can't get one because every time you go into a health clinic, you're not getting the right service or you know, people put you on a waiting list. It could be you live in a community that's doesn't have a great public transport in order for you to get to where you need to be in order to access care. It could be that you're unemployed, and so you know, your ability to access certain opportunities is limited because you know your resources are limited. It's these really practical things that cumulatively really have an impact on people's life chances and health. So, you know, the men that we spoke to as part of this study described their lives often through or in relation to these structural barriers. These structural barriers inform who they are and how they understand the world. So it's really a basis from which to think about what it means to be a Black man in Canada. And if you don't take these barriers into consideration, you're missing the bigger picture.
It encompasses the lived experiences of Black men. So maybe the one I will just narrow down to is the issue of healthcare access, right? And maybe even bringing it down to the issue of HIV. So typically you have like two groups of people that are extremely vulnerable to HIV, right? So one group seems to have a lot of resources, seems to have a lot of attention being paid to it. There seems to be some kind of compassion towards this group addressing the issue of HIV. But when it comes to the other group, which is a Black group, you realize that these structures are not there. The narratives that frame how they become vulnerable to HIV is totally different. They go to AIDS service organizations, they don't have people that look like them. So in my own experience, for instance, the regional HIV/AIDS connection in London, Ontario, the first time I decided to go there, have a talk. Considering the fact that about 25% of risk, new HIV infections are attributable to our community, I was extremely surprised not to find 25% of people that look like me working in those spaces, right? You go there are no translation services. People can't simply access these services or because they have no connection to these places. So those are some of the practical issues that we are talking about. So people that have, let's say, needs for HIV services are people that will never connect to these places. So you just think about this scenario and just multiply it with regards to every sector of the Caribbean space. When it comes to employment, it comes to housing, it comes to education, it comes to almost everything. Black people are always finding themselves at the bottom of that ladder, right? And it becomes extremely difficult for them to climb to the top, to be able to access all the benefits that comes with living with dignity within Canada here.
From what you've just said and how there is this issue of lack of access for a certain group in the society. Now, if you have conversations with some of them, which is what I have noticed in the course of reporting issues concerning the African, Caribbean, and Black people, they're always tied to racism. Do you agree?
Yeah, I think racism is a big part of what we're seeing. And it's not just racism, it's a particular kind of racism. It's what I would describe as anti-Black racism, and it's systemic. It's a part of our institutions. It's a part of our culture. And to say that we're up against a systemic form of racism doesn't mean that we're all just simply victims because we're Black. That's not what I'm saying. I'm saying that because we're up against a system that produces disadvantage on the basis of who we are, that puts us at it puts us in a situation where we constantly have to work more for the same things that other groups have. And of course, you know, our communities are broad. And I often hear from folks when we talk about racism, people might say, well, wait a second, so-and-so is very successful, or this particular community within the Black community has done very well for themselves. And they're right, you know, I mean, it's not just because we're Black that we're unable to access opportunities, but overall, when you look at our community, systemic racism has really impacted us. And that's what we're trying to get at. So we think about the collective experience as opposed to the individual experience, though the two are very much related.
So for instance, you are born in Canada, like two children can be born. One may look like me, another one may not look like me, another one may look like the more dominant population. And years down the line, these two children are going to have different world outcomes or different outcomes simply based on how they look like. Right? So if that's not racism, then you tell me exactly what it is, right? So I remember when I was in graduate school myself, one of the things my own supervisor told me that as a Black man, for you to be recognized or for you to be taken seriously for who you are, you have to work twice, 3 times as hard as somebody that is like that belongs to the more dominant population. So it is only within a system where people are discriminated based on how they look like, based on how they appear, based on how they talk, or based on the assumptions that have been made about them for the way they look like, that will produce this kind of outcome. So very much anti-Black racism is what it is, and that's what has actually reproduced or has produced some of the outcomes that we have. So for instance, the issue of HIV, and I keep coming back to it, why has it become a problem within the Black community? It is simply because people or policy decided not to pay attention. Right? So whilst the focus was on other groups, for Black people or for the Black community, the narrative has been that, oh, they bring all this calamity upon themselves. They are not responsible. They are sexually responsible. They take risks. So just let's leave them to handle their own issues, and let's concentrate on other population as well. So these are some of the issues, and this is typically tied to the issue of anti-Black racism, and that's what has produced some of these outcomes that we continue to live in Canada here.
How does the study intend to engage policymakers while sustaining the dialogue to reduce HIV-related health disparities among Black men and the ACB communities?
Experiences around HIV are always in relation to other things, in relation to your identity, in relation to your social location. So one of the greatest findings of this particular study is really letting our policymakers know and decision makers that, hey, when we think about Black people's health, we need to think about it holistically. When we try to support people living with HIV, we can't only care for their HIV. We have to take into consideration their housing and their immigration experience and their experience with discrimination and their families and the communities they live in.
There are a number of strategies that we have also outlined. So first, as Wesley said, is first thinking about health in a holistic manner. You don't have to think about health as in a very compartmentalized unit. They're actually linked. So people's issues of housing, issues of neighborhood, issue of racism, police brutality, all those things are things that are ultimately linked to the health of Black people or the vulnerability of Black people to HIV. So we first have to think about how we can substantially reduce the issue of anti-Black racism and take Black people more seriously for what they say. But I think one of the major issues for us is, at least in the first place, we have been able to talk to Black people. So instead of other people telling Black people their stories for them, telling the story about how they are vulnerable, how they become vulnerable to HIV, this particular research has actually given a voice to the Black community, has given a voice to heterosexual men to tell the story about their vulnerability themselves. So it's not just an issue about their sexual promiscuity, issues of practice of traditional masculinity. It's about the lack of opportunities like any other Canadian, right? So these are the things that make them vulnerable. This study has also done a number of things by engaging service providers, telling them these are the issues, these are some of the concerns that have been raised by the Black population. So how do you engage them? How do you bring them together? How do you listen to their voice? How do you incorporate some of the concerns into the way you deliver your service? Another issue is for us to actually think about how we can give a voice to Black people in general. So how can we create safe spaces? In fact, one of the things that emerged from one thing we did, we call it the concept mapping, presenting the findings back to Black men and telling them, okay, this is what we have. So what are the priority for solutions to your problem? And for most Black people, what I was actually surprised about is that for most Black people, this is the first attempt that they have experienced where people are interested in them talking about their health, interested in them talking about some of the vulnerabilities that they faced in the context of Canada here. So for them, it was a very empowering thing for them because they have never had opportunity even to talk among their peers about issues of HIV, about issues of their health. So we have to also think about how we can create safe spaces to continuously engage Black people or Black men in issues of HIV. One of the things that I'm also very happy about is that we also had a number of things emerging as to how Black people are also resilient. The previous, like if you just check out the framing about Black people's health and how they suffer poor health outcomes, the narrative has been that this is a group of people that just simply don't care. But the weSpeak findings have told us that in fact, Black people are engaged in a number of activities that has made them, despite all the systemic discrimination and oppression and everything they face, they have been able to mobilize themselves and they have been able to do very positive things that reduces the kind of impact all these things have on them with regards to their health outcomes. So they're also very resilient. So in a context where nobody's listening to them, nobody's giving them any opportunity, the framings about their health is very bad. They have still been able to keep themselves afloat and also continuously engage and take care of themselves and their families as well. So that's also one positive thing that came out from this study.
In order for us to really realize our vision here, we need to make sure that our system leaders and policymakers make the resources available in order to continue this work, right? This work needs resources, real resources, and we're there. So it's a battle, right? We're advocating for this, but I think we're on the right track.
Yes, I know this projects like this are capital intensive, and I do hope that your team will keep that going. Rogers, you wanted to ask something?
Yeah. So thank you. Yeah. So I think even with this podcast is something that is geared towards, making as many Black people and even policymakers aware of whatever that's happening within the Black community. So there have been a number of strategies, a number of ways that we are engaging. So each site, Windsor, Toronto, London, and Ottawa, each site has also designed its own community outreach and knowledge translation tools where they're engaging the local service providers and the health policymakers at that level to be able to continuously engage the Black community as to how best they can serve them when it comes to their health. But I think for me, whilst most researchers or people that are on this project are also looking for new funding opportunities and also looking for other opportunities to continuously engage in research like this. For me, one of the greatest benefits to ensure the longevity of this kind of research is what Wesley spoke about at the beginning of this particular podcast about the issue of mentorship. So I've seen a number of young people that have been part of this project, that have this passion, that have developed the passion to make the necessary change within the Black community, to be able to help the Black community tell their own story, to be able to put into perspective what makes the Black population more vulnerable when it comes to some health outcomes. So that particular mentorship is actually something that within the nearest future is actually going to explode and is going to reap the benefit for Black for Black Canadians.
And I hope, Wesley, you and Roger are paying it forward by mentoring more younger people to keep the work going.
Well, yes. I mean, we're the recipients of great mentorship. I mean, we do a bit of mentorship on our own, but we've really benefited from an entire community that has placed enormous trust in us and has carried us along the way. And I'm still learning, and I'm grateful for people like Winston Husbands and Josephine Wong and others who continue to pave the way for this work.
The fourth episode of the podcast will analyze the dialogue with community stakeholders. weSpeak research is funded by the Ontario HIV Treatment Network and the Canadian Institutes of Health Research.